Most of what I'm going to talk about, it does come from the 2020 guidelines that I was privileged to be the chair of, and I had to laugh because I used to have a slide immediately after this one that talked about how guidelines aren't law, but Kevin beat me to that this morning. Guidelines are not policy. They are to help us get on the same page, but we also need to recognize human biology and anatomy don't always follow a template, so it doesn't give us a reason to abdicate our thoughts about thinking through a patient situation, identifying when they don't fit the pattern, and so certain recommendations might not fit those. So we're going to talk in general terms about hypertrophic cardiomyopathy this morning. These are the top 10 take-home messages from the guidelines. We will hit on most of these during the coming slides. I won't spend any time, however, talking about sudden cardiac death risk in children. I don't practice pediatric HCM, so we won't get into that very much. So one of the first things we did in the guideline this last time was, as we have in many cardiology fields, focus on the concept of shared decision-making. Not so much putting out tools for that, but getting people away from making dogmatic recommendations for patients in a very paternalistic way that took patients' thoughts about their own goals for health and wellness out of the equation. So getting back into that discussion about helping patients make therapeutic choices. And it's particularly relevant in HCM because we're not overloaded with all these huge randomized controlled trials with irrefutable evidence about the benefits of certain agents and other ones. It's a lot of consensus, observational studies, those types of things. And those concepts need to be clear that all of this are shades of gray in HCM. We also, for the first time, put some information in a guideline. Prior to this, the guideline task force didn't allow guideline writing committees to talk about centers of excellence, or what we called comprehensive or multidisciplinary centers. And we felt it was really important here because there are clear data that for some of the procedures that are specific to HCM, there is a huge difference in outcomes based on where you get that done. Like I used to show a slide that if you get your myectomy done at the lowest tertile care, 1 in 6 patients dies having a myectomy. But if you put the 5 largest HCM programs together, 1 in 1,500 patients dies getting a myectomy. So patients really should be afforded the opportunity to see those centers. And the other thing that I said, and it's here on the slide, is when it took us in the writing committee days to come up with the wording for any Class 2B recommendation, if you're thinking about starting a Class 2B diagnostic or therapeutic decision with a patient, that's probably when you should have someone who is really intricately involved with thinking about this day in and day out, because it's hard for us in any field or any subsegment of cardiology to cross over to that nuanced 2B discussion with a patient in that area where we're not an expert. And the idea is not that the HCM centers want to take patients and manage them from A to Z, but rather they want to participate as part of a team with patients that include cardiologists not working in HCM centers, but the patient is in the middle, not who the care team is. We also put some target expected metrics that patients should be expect from where they're getting their therapies. And this is in the slides in the handout. It's actually published in the guidelines, so I'm not going to go over these in detail, but these are reasonable expectations of what patients should be able to achieve. Now, we did do some updating of the family screening recommendations, principally around when do you start screening kids. So if families want to choose genetic testing, that is still a very good option. That is actually the only role for genetic testing in HCM is family screening. The issues are that 50% of the time, 60% of the time, we don't get a helpful genetic test result because there are so many variants and there are so many gaps that many insurance plans don't cover the cost of genetic testing for families, and so it might not make sense for an individual family to choose that. If they don't choose to do genetic testing, or if that test comes back with a variant of uncertain significance or no variant identified, that doesn't mean they don't have HCM. It just means we didn't identify their disease-associated variant. But then they must get an echo imaging screening protocol for their family. No different for adults. Adult first-degree relatives of HCM patients should get screened every 3 to 5 years. You can start screening children at any age. for patients with HCM who they do have a gene, those gene-positive children, only 5% of them will show hypertrophy under the age of 10. But that doesn't mean you can't start testing them. Particularly, echo is a zero-risk test. So if it's going to help the family deal with anxiety of unknown and those types of things, screen them at any age. But you shouldn't wait until they're mid-teens if you're going to do it. Usually the latest you want to start is kind of the onset of puberty. But if they are from a family that has had a lot of early onset HCM, or they've had more than one sudden death in the family, that's probably your clue that you want to screen that family a little earlier, or their kiddos. And so we were more explicit about that. Not much change in cardiac imaging other than some more specific discussion on when a cardiac MRI should be used. It's really important when there is diagnostic uncertainty. As we all recognize, MRI has different spatial resolution than echo can have, particularly as our society gets more and more obese. The echo imaging becomes more difficult, and that's when MRIs can be helpful, particularly if you don't see the whole heart. And then also, when we get into the sudden cardiac death risk assessment section, if a patient isn't already identified as high risk and or hasn't already made a decision about they're absolutely going to get an ICD or they're absolutely never going to get an ICD, then MRI does contribute to further risk stratification. So the bottom line is that CMR is useful in a lot of patients with HCM, but it's not mandatory in all patients with HCM. Echocardiography, on the other hand, is mandatory in all patients with HCM. It is the single most effective tool we have for the diagnosis and understanding the pathophysiology that's impacting that patient that you're dealing with. So echo for all, CMR for a lot. Assessment of sudden cardiac death risk continues to be one of the longest aspects of any patient encounter that I have. And again, I mentioned that the issues with children is the risk factors don't have the same weight, and they're not quite the same risk factors in children as they are in adults. And if you are someone who deals with children, you're familiar with the fact that the decision to put a device in a child, particularly if they have to grow a lot more, changes some of your decisions and thresholds to place devices. So it's a very complicated area. The reason why this is an issue is this is the first report about HCM that's recognized in the literature from 1958. All 8 of these patients were dead. This was an autopsy series, so when we first heard about HCM, it was universally fatal by age 50. We know that's not true anymore. The sudden cardiac death rate is 0.8% per year in HCM patients, 0.8% per year. So there's been a lot of history looking at what can help us identify those patients who are at high risk and or those patients who have the lowest possible risk. And there's a whole bunch of things that have been tested. The items in this slide that are in blue are the ones that have kind of stood the test of time, and the bolded and underlined ones are the ones that get the most weight in current risk assessment algorithms. So how do we do this? Well, it's been quite a journey. Prior to a decade ago, we simply counted the number of risk factors that a patient had and reassured them if they had none, and suggested they get an ICD if they had 2 or more, and then debated about whether 1 was enough or not. And every ACC and AHA and ESC conference had a debate of someone saying that 1 risk factor was sufficient to suggest an ICD and someone else saying you had to have at least 2. And it kind of fell down by if you lived in North America, you were more likely to get an ICD than if you lived in Europe. So this is kind of the way it would have worked if on these 5 theoretical patients who all have some degree of risk. Family history of sudden death in the first one, a really thick heart and non-sustained VT in the second one, non-sustained VT and a blood pressure that drops during exercise, massive hypertrophy, and the bottom one had no risk factors. And so, that's kind of how they would have been dealt with in 2010. Then we published guidelines in 2011 that Dr. Gersh and Dr. Marin were the chairs of, and I got to participate in that. And we tried to give some hierarchy to the risk factors based on the weight that we saw and the level of evidence. And family history of sudden cardiac death or massive hypertrophy, more than 30 millimeters, or recent arrhythmic sounding syncope had greater weight in the studies that have been published, and so we made those class 2A indications. Non-sustained VT and abnormal blood pressure response on their own were really not so well supported, and so made those class 2B unless there was other risk factors or near risk factors that were present with them. And that's where we came up with these different classes of risk factors. And so following that guideline, all 4 of those first patients would have had class 2A indications for ICDs, and the last patient would have had no indication for an ICD. Challenges here are that 29 millimeters in that 19-year-old. Are we certain that that's not 30 millimeters? And we know that the risk isn't low at 29 and high at 30. We know that it's curvilinear. So treating a linear variable as a binary variable can cause some challenges in practice, again, particularly if we're not trying to be thinking cardiologists. And this is where guidelines can be issues. Everyone wanted to write articles about whether appropriate patients got ICDs. Well, remember, 2A doesn't mean the patient has to get an ICD. It's not a law that a patient get an ICD if they have a class 2A indication. The patient should have an opportunity to say, no thanks, I don't want an implanted device in my body. But the patient needs to get communicated that they have some level of risk, and I'll tell you how we do that based on the new 2020 guidelines. What was really helpful is when our colleagues in London published this HCM sudden cardiac death risk calculator, because it allowed us to communicate with patients the magnitude of their risk based on some of their echocardiographic and demographic parameters. So the data that are in the screen here, and it's not important, even though this person has risk markers, their risk at 5 years is only 2.5%. So being able to put that magnitude in front of a patient rather than just saying, you have risk, well, how much risk? Is it a 50-50 thing? No, it's 2.5% for this patient. The challenge with what the Europeans did in their guidelines was they created pre-specified cutoff values of who was eligible based on risk values. So they didn't let the patient tell them what their risk tolerance was. They just said if you have 6% risk or higher, you should get an ICD, and if it's less than 4%, you shouldn't get an ICD. Well, that's a pretty narrow range to think about that, and again, it takes the patient out of the discussion. But that's what those 5 patients' estimated 5-year risk would be. So remember, the average patient with HCM is going to have a risk of between 4 and 5% at 5 years, 0.8 times 5 years. So again, the second one in particular calculates quite high because it's a young patient with that near 30 millimeter risk factor. But the 2 with the green check marks would have likely gotten defibrillators based on that ESC calculator. But so what we decided to do was to combine the best of both of those worlds. And so we re-looked at the literature, again, affirmed that family history of sudden death and massive LVH and arrhythmic syncope were important, but also added an LV apical aneurysm, so a true aneurysm with scar is a clear risk factor for VT and sudden death in patients with HCM, as is an EF less than 50%. So we added those to the important risk factors. We kind of dropped abnormal blood pressure response because A, it's difficult to ascertain, and B, sometimes that's due to hemodynamic phenomena that aren't dangerous to the patient in an arrhythmogenic way. And so that one dropped off, and then non-sustained VT is there, but it kind of bifurcates. It's more important in kids than it is in adults. So how I use, and we added CMR at the bottom there as well as in isolation, that's a class 2B indication. So the way I use this when I'm talking to patients is this: the presence of any of those risk factors, those are highly sensitive markers to identify someone who has higher risk than someone who doesn't have those risk factors. So those essentially tell us who is eligible to get an ICD. In the absence of any of those things, the patient doesn't really have eligibility for an ICD. And so then I tell our patients, yes, you're eligible for an ICD, and we kind of have 3 grades of that eligibility. The highest level of eligibility are patients who we've resuscitated. They've had a cardiac arrest or sustained ventricular arrhythmia already. The next one down is most cardiologists that treat HCM would think it's reasonable for you to get a defibrillator with this, which by definition means it's reasonable for you to think about it and say no thank you if we've had a thorough discussion. And the bottom level of eligibility is there's some increased risk. It's probably not high, but you are eligible if you find that fact that you have risk anxiety provoking. And then I use that calculator to help communicate what their individual risk level is based on that calculator. Now we talk about shared decision making like it's a new thing, but Whenever Kevin sees a patient, he tells them what he thinks their operative complication rate's going to be. We've been doing this for years. We've just put a new title on it called shared decision making. We don't just say, yeah, your aortic valve surgery is going to be really risky, but we'll see you on Tuesday. The patient will, well, how risky? What do you mean? What are the risks involved? And that's what we're doing here, is trying to share the fact that patients have risk and what the magnitude of their risk is so that they can participate in the discussion about whether or not they want an ICD. So all of these patients, again, would have been class 2A, and so 3 of these patients are still alive. 2 of them did have cardiac arrest. None of the patients got an ICD. They all opted out after the discussion. But I put this up here just to say those risk, those percentages are fairly accurate. I mean, even the patients with 0 risk factor, there are some patients who will have cardiac arrest there. And communicating that to families, that there's no such thing as a 0 risk patient, is an important part of that discussion, so that their family isn't totally shocked if an event like that happens to that 36-year-old man. We did redo the calculators, and so both American Heart Association and American Cardiology in their guidelines apps, the calculator is there. You can input the information. It tells you what the class of recommendation is, 1, 2A, 2B, based on the presence or absence of risk factors, and gives you that 5-year risk score. The class of recommendation is not based on the percentages. That's there for your discussion with the patient. There wasn't a lot of update in septal reduction therapies, so surgical myectomy or alcohol septal ablation. Some subtle things we did in terms of identifying which procedures might be better for which patients and which circumstances. But then remember, what we're trying to do here is treat this pathophysiology, which is so important in HCM, and nearly 70% of patients with HCM will have left ventricular outflow tract obstruction. It causes subendocardial ischemia through supply-demand mismatch. The mitral valve gets pushed in an abnormal position, so it leaks, which causes increased mitral regurgitation and increased left atrial pressure. And all that stuff also worsens the diastolic dysfunction. The obstruction is highly dynamic, as we've talked about for a number of years. It gets worse when the heart beats harder, or when the afterload blood pressure is dropped, or if the patient gets dehydrated. All those things make the gradient get worse. It is something that we can manipulate by altering some of the functional aspects of the way the heart works, and that's why medical therapy can be so successful. We do like to point out that obstruction is defined at a gradient of 30. We think it takes a gradient of 40 to 50 for someone to be highly symptomatic. The point of that is, if you have someone who has class 3 or beyond symptoms and you're only getting a gradient of 35, either you need to look harder for more gradient, or you need to look harder for another cause for their shortness of breath. So I mentioned the obstruction is highly dynamic. All of these things happen when we stand up and walk across the room. And that's, most patients with HCM do not have resting symptoms. Most patients with HCM only have exertional symptoms. The mainstay of therapies are beta blockers, verapamil or diltiazem. They are negative inotropes, and they slow the heart rate down and give it more time to fill, so you're maximizing preload with each heartbeat. We'd like to get people off of vasodilators, because that can make the gradient worse if you have a pure vasodilator, and we like our patients to stay hydrated. This is old data now, but it was 1,500 consecutive patients referred to us for surgical intervention, and you can see that 2/3 of those patients we managed by optimizing their medications they were on. Now, people often ask, what about people who have concomitant hypertension? How do we treat that when someone has obstructive HCM? Well, the first thing you try to do is get them off of vasodilators and onto the beta blockers, verapamil or diltiazem. They're antihypertensive agents. Often that works, or at least you can minimize that vasodilator and then get them on one of these other agents. I still use thiazide diuretics for hypertension, very effective, very cost effective, and usually at low doses they're not dropping the preload much. It's more the antihypertensive therapies we're after. Or you can move to clonidine, a centrally acting agent, to manage their hypertension. The indications for myectomy and ablation are drug refractory symptoms due to obstruction. This is kind of the scorecard of the differences between the two. There are advantages and disadvantages of both. Myectomy, the surgeon can do more. They can get in there, resect more tissue, customize their resection to the problem that that particular patient brings. But it is cardiac surgery. It's done through a sternotomy. It's a cardiopulmonary bypass procedure, so it's 5 days in the hospital and all the attendant things that go with having a big incision in your chest. On the other hand, outcomes are very good. Survival is normalized following successful myectomy, and the complication rates in general are about 1% to 2%. Ablation comes with a much shorter hospital stay, less pain, and return to activity or work much sooner than someone who has had surgery. Can't quite do as much. The success rate with ablation is about 85% versus 95% for myectomy. And of that 85%, about 10% of those need to have more than one ablation to achieve full effect. So this is some of the discussion we have with our patients in those situations. So this is the algorithm from the management guidelines. So the first thing you do is if a patient's asymptomatic, you don't have to do anything. There's no proven benefit to medicines in HCM other than relieving symptoms. So if they're active and asymptomatic, you don't have to do anything other than see them back in a year. Otherwise, you try to get them off of offending agents and onto those first-line therapies. If they're asymptomatic with that, then they go into their review cycle. If they're still symptomatic, as we see over here, then you can consider adding disopyramide or moving to one of the invasive procedures. Sometimes mechanical problems need mechanical solutions, and that's why myectomy becomes so effective for patients who have very high gradients and very thick hearts or intolerance to the drugs. Now, HCM at the cellular level is often due to problems with the cardiac sarcomere, and in particular, there's too much interaction between actin and myosin. They don't let each other go to relax, and it's a hypercontractile state that occurs at the cellular level. The new class of agents that is highlighted by mavacamten, which is not yet FDA approved, it is due to have a ruling by the end of April, targets the actin-myosin complex and tries to make them less sticky to one another. And so this trial was released in 2020 as well. It was a 30-week trial that showed 37% of patients treated with the active agents achieved a study endpoint of a little increase in VO2 and a 1 NYHA class change. But note that also 17% of the placebo patients do. So the net benefit was 1 in 5 patients on the study drug got better by 1 NYHA class and also with some objective evidence. So it's not a home run in terms of a drug. It's getting lots of press and everyone, lots of money put behind this drug, but it's not like most patients got better. Some patients got better, and it will have a role in the management of HCM, but there's also the troubling fact on the bottom there that 1 in 10 patients dropped their EF to less than 50% on this drug, which is why the FDA ruling was pushed from January to April, so they could think about a safety monitoring program. If you compare that to disopyramide, it's a similar reduction in gradient, similar drug intolerance. So again, we're super excited that drug companies are paying attention to HCM as a primary target for drug development, but this is not going to substantially change the way we manage HCM patients in the near future. We don't know about the durability of treatment beyond 30 weeks. We don't know the long-term safety, particularly amongst those who dropped their EF. We do know that so far every patient who that happened, their EF normalized once the drug was stopped. And we don't know how the company is going to price the agent. So I think those agents will fit out there somewhere as an alternative to invasive therapies. Someone who's frail or not yet ready to commit to having an operation or ablation done, it might be a great place to try that. Or someone who has to have some other surgery coming up, the pancreatic Whipple that Kevin, if they had HCM, maybe you put them on mavacamten or something similar to that to get them through that period. But we will have to see more data to know exactly the place in therapy for these agents. Atrial fibrillation, remember, we don't use CHADS-VASc to assess anticoagulation risk in HCM patients. Having HCM plus AFib, the stroke rate is 3% per year. That's the equivalent of a CHADS-VASc score of 3. So we just automatically recommend DOAC or vitamin K for patients who have substantial AFib and HCM. Heart failure is managed like heart failure if they don't have obstruction. So most patients are treated like they're HFpEF patients if they have HCM and no obstruction. HFrEF in HCM is defined as an EF of less than 50, not less than 40 like it is in other cardiomyopathies. And then exercise was the last thing we addressed. There is data now that shows that low to moderate intensity exercise has beneficial long-term health consequences for HCM patients, just like it does for the rest of us. So we should stop telling them not to be active and that they can be active like the rest of us are. The continued debate has to do with participation in athletics. And all of this comes on the fact that there's data that has shown that amongst dead athletes, HCM is overrepresented. That doesn't tell us amongst living HCM patients, is it more risky to be athletic or non-athletic? It just simply tells us that being an athlete with HCM is higher risk than being an athlete without HCM, but we don't have any direct studies for the right-hand comparison of athletes with HCM to non-athletes with HCM. Observational data would say Dr. Marin's study showed 4 cardiac deaths per year roughly in college-level athletes due to HCM. If you do the math of the number of college athletes, prevalence of HCM, sudden death rate, you would have predicted 3 to 3.5 deaths per year. So is 4 deaths per year different than 3 to 3.5 per year? We don't know. You'd need a study of 3,500 patients in each arm for 10 years to determine that, and that's just unlikely to happen. So rather than dogmatically tell these young athletes that they cannot play any longer, this is again a shared decision-making discussion where we say, gosh, you do have some risk. As long as you understand that and knowing that we can't magnify that risk, the decision to continue to be active is the individual person's decision. Now, that doesn't mean an individual team has to take them. That means that person can choose to pursue someone who would support them in an athletic career. And so that is a very complicated discussion. And my last slide here is this is what every patient who leaves the clinic needs to understand. They're not alone. There's 500,000 patients with HCM in the United States. Overall, most people with HCM live a normal number of years and die from something else. Their first-degree family members need screening. We do have to look at that sudden cardiac death discussion with each patient. We only use medications and invasive therapies to treat symptoms and be healthy. Thank you very much.